Hi, I'm Dr. Andrew New. I'm the Medical Director for Emergency Psychiatry at Northwestern Medicine.
Hi, my name is Emma Baer. I'm a clinical nurse for the Psychiatric Emergency Program at Northwestern Medicine.
So at Northwestern Medicine, our emergency psychiatry program, we see a lot of patients every day. The numbers in the emergency room can fluctuate, but the mental health patients really do take up a large portion of them. Some days it can be as much as 20-30% of the population in the emergency room. As the pandemic ended, there's still a very high rate of mental health illness coming through the emergency room, and our psychiatric space was getting overburdened. We're here to help our patients, and ultimately sometimes the space is actually making things harder and worse. We so often isolate our mentally ill when they're going through a crisis that they need to be more connected with mental health workers on a regular basis, as opposed to just sitting and waiting in the ER. We operate under a consult-only model in which the psychiatrist would provide recommendations to the emergency department, but they weren't actively a part of the team. When I came in, we switched our process to what we call a co-management model. We wanted to open up a new space that would afford our patients more interactions with people that are trained in mental health techniques.
So the Behavioral Health Suite, or the BHS as we abbreviate it, is a 3-bed area that is set up specifically for psychiatric patients. The area is right next to the social workers, the mental health nurses, and the psychiatrist, and it provides an experience for the patients that's more similar to what an inpatient psychiatric setting would be.
Without this, our patients had to just remain in the emergency room until they were able to get to a psychiatric inpatient unit. What this allows for us is we can actually start treatment while they're in the ER. We also have rec therapists that can come down and engage in leisure activities with them, such as coloring Sudokus. It doesn't sound like much, but boredom can be extremely painful. And so providing these kind of comfort measures to patients is a wonderful thing to do when somebody's going through an acute crisis like this. Previously, we weren't able to engage what we call psychiatric observation, in which a patient's actually held in the ER for 24 to 72 hours. This provides us a chance for any cases in which there's diagnostic uncertainty to get a better understanding of what's actually going on before we commit somebody to admitting them to an inpatient psychiatric hospital. So for our patients that are in the emergency room and might have been admitted, this gives us a chance to actually see if what they're going through can be resolved before even having to go into a hospital. So for the people being discharged, this gives them a wonderful chance to actually get significant amount of care before leaving the hospital. We can start medications, we can titrate the medications, see if they're having any adverse effects to them. It gives us plenty of time to actually coordinate disposition and getting them connected with an outpatient provider as well. Classically, the ER is much more about stabilization than it is about starting and managing treatment, and so this gives them a higher level of care. As far as the city of Chicago goes, currently there's only approximately 4 hospitals, emergency rooms, that actually have a psychiatrist in them, and none of them actually offer this level of observation care. And so this is a new thing that we're trying to bring to the city of Chicago and allowing people a chance for a more full, more extensive evaluation prior to saying that they need to be admitted to psychiatry.
So I'm really passionate about this program because I enjoy working with the mental health population. I think it's really important for our community, and I think it's important for this hospital making new programs of how to help those that are struggling with different issues. And as a nurse, it's encouraging to get to help people with their next steps in treatment.
So the education aspect of this is crucial. As we move to a co-management model, we have to know what the other person's thinking and wanting to do and how we're going to proceed for this patient. I started giving lectures to the emergency medicine residents, the emergency room nurses, and also the mid-level providers. Once I gave one lecture, they started to ask for more, and we started to share knowledge, and it was a wonderful experience. It's become much more collaborative, and it's helped really break down some silos.
So I think that this gives us an opportunity as staff members to learn from each other and to see how we can better take care of the patients in a more well-rounded way. The emergency department nurses and the behavioral health nurses to work together and to better care for the patients that we're jointly taking care of.
I love the idea of working with emergency psychiatry because I can see anyone. I don't care if you have insurance, you don't have insurance, you have a house, you don't have a house. I'm here to help you. These people are going through extreme crises, and without somebody that can understand and empathize with them, you can make it worse.